in pregnancy based upon the BHIVA guideline. Okay, so first of all, we will discuss the perinatal mental health assessment. Assessment of antenatal and postnatal depression should be undertaken at booking at 4 to 6 weeks postpartum and 3 to 4 months postpartum in accordance with the National Institute for Care and Health Excellence, means the NICE guideline. Okay, laboratory monitoring of the patient with HIV is very important. It's a little bit congested slide, but it would be very better if you listen to me carefully because there are very important points discussed in this slide. Okay, so pregnant women who are newly diagnosed with HIV do not require any additional baseline investigation compared with the non-pregnant women living with HIV other than those routinely performed in general antenatal clinic. Okay, so HIV resistance testing should be completed and the test available prior to initiation of the treatment, except for the late presenting women after 28 weeks. Women should be encouraged to continue combination ART post delivery, but where they choose to stop CART, a further assistance test is recommended to ensure that mutations are not missed with the reversion during the off treatment period. In a woman conceiving on CART, there should be a minimum of one CD4 count at the baseline and one at delivery. In women who commence CART in the pregnancy, a CD4 count should be performed as per routine initiation of CART with the addition of a CD4 count at delivery, even if starting at CD4 count of more than 350 cells per millimeter cube. In a woman who commence CART in a pregnancy, an HIV viral load should be performed 2 to 4 weeks after commencing CART at least once every trimester at 36 weeks and at delivery. In women commencing CART in a pregnancy, liver function test should be performed as per routine initiation of CART and then with each routine blood test. In the event that the woman who has initiated CART during pregnancy has not suppressed plasma viral load of less than 50 HIV RNA copies per ml, the following interventions are recommended. First of all, review adherence, including a full exploration of potential impacting factors and concomitant medications. Perform resistance test if appropriate. Consider therapeutic drug monitoring. Optimize to best regimen and consider intensification. Now coming to laboratory monitoring of pregnant women living with HIV. HIV resistance testing should be completed and the results available prior to initiation of the treatment, except for the late presenting women after 28 weeks in the start of treatment immediately. A CD4 count, taking CART from before pregnancy at booking and delivery, initiation of CART during pregnancy, at initiation of therapy and at delivery. Viral load, 2 to 4 weeks after commencing CART at least once every trimester at 36 weeks and at delivery. Liver function test, initiation of CART and with each blood test. Now, conceiving on CART, it is recommended that women conceiving on an effective CART regimen should continue this treatment. Exceptions are non-standard regimen, for example, protease inhibitor monotherapy. Regimens that have been demonstrated to show lower pharmacokinetics in women in pregnancy, such as darunavir, cobicistat, and alveltigravir, cobicistat, or where there is absence of pharmacokinetic data, such as for raltegravir 1200 mg once daily OD should be administered 400 mg twice daily PD. And these should be modified to include, depending on tolerability, resistance, and prior antiretroviral history, one or more agents that cross the placenta. A woman conceiving on dolutegravir should see her physician as soon as possible to discuss current evidence on neural tube defect. Women not already on CRT want to start. All the women including elite controller, should start ART during pregnancy and be advised to continue lifelong treatment. All women not on CRT should commence CRT as soon as they are able to do so in the first and second trimester, where the baseline viral load is less than 30,000 HIV RNA copies per ml, and at the start of the second trimester or as soon as possible thereafter in women with a baseline viral load of 30,000 to 100,000 HIV RNA copies per ml, and within the first trimester if viral load of more than 100,000 HIV RNA copies per ml or CD4 cell count of less than 200 cells per millimeter cube. All women should have commenced CART by the 24 weeks of pregnancy. Now, women not already on CART, what should start? Women are recommended to start tenofovir TF or abacavir with M3-cetabine or lamivudine as nucleoside backbone. It is recommended that third agent in the CART should be efavirenz or atazanavir, as these are agents with the most safety data in pregnancy. Now, rilpivirine 25 mg OD or raltegravir 400 mg BD or darunavir 600 per 100 mg BD may be used as alternative. And darunavir should be prescribed at twice daily doses 600 per 100 milligram BD if non-resistance, and consideration should be given to using this higher dose if darunavir is initiated in pregnancy. Dolutegravir 50 milligram OD may be considered from 6 weeks of gestation, which must be confirmed. Zidovudine monotherapy is not recommended and should only be used in women declining CART with a viral load of less than 10,000 HIV RNA copies per ml and willing to have a cesarean section. Now, PL monotherapy, tenofovir, alafenamide, darunavir, cobicistat, and alveltegravir cobicistats are not recommended in pregnancy. It is recommended that integrase inhibitor-based regimen be considered as third-line agent of choice in a patient with a high baseline viral load of more than 100,000 HIV RNA copies per ml, where CART is falling to suppress the virus. A woman who presents after 28 weeks should commence CART without delay. If the viral load is unknown or more than 100,000 copies HIV copies per ml, a 3 or 4 drug regimen that include raltegravir 400 mg BD or dolutegravir 50 mg OD is suggested. Management of an untreated woman presenting in labor or term, all the women should be given start dose of nevirapine 200 mg and commence oral zidovudine 300 mg and lamivudine 150 mg BD and raltegravir 400 mg BD and receive intravenous zidovudine for the duration of the labor. In a preterm labor, if infant is unlikely to be able to absorb oral medications, consider addition of double dose tenofovir to the woman's treatment prescribed in the recommendation. Women presenting in labor with a spontaneous rupture of the membrane requiring delivery without a documented HIV results must be advised to have urgent HIV test. A reactive positive results must be acted upon immediately with the initiation of intervention to prevent vertical transmission of HIV without waiting for further formal serological confirmation. Now, who are elite controller? There are a small proportion of HIV positive women, people who have undetectable viral load on different assays known as elite controllers. Pregnant women in this group should be treated with CART or monotherapy with zidovudine. Monotherapy with other agent is not recommended and women is advised to exclusively formula feed. There is no evidence that CART is superior to zidovudine alone in reducing vaginal shedding. Hence, zidovudine monotherapy is an acceptable choice. Now, management of untreated women presenting in labor at term. All the women should be given a start dose of nevirapine 200 milligram and commence oral zidovudine 300 milligram and lamivudine 150 milligram BD and reltigravir 400 milligram BD and receive intravenous zidovudine for the duration of labor. Now, which patients are candidate for integrase inhibitor based regimen? It is recommended that an integrase inhibitor based regimen be considered as the third agent of choice in the patients with a high baseline viral load of more than 100,000 HIV RNA copies per ml, where CRT is falling to suppress the virus. And recommended and alternative agents in pregnancy, nucleoside reverse transcriptase inhibitor backbone, and third agent, nucleoside reverse transcriptase inhibitor backbone includes the recommended drugs like abacavir, lamivudine, tenofovir, DFM, and emtricitabine. Third agent recommended doses include efavirenz and atazanavir. And alternative or nucleoside reverse transcriptase inhibitor backbone include zidovudine and lamivudine, and alternative of third agent include rilpivirine, darunavir, reltigravir 400 mg BD, dolutegravir after 6 weeks of gestation. Now, for women on dolutegravir wishing to conceive, women should be fully informed that the prevalence of neural tube defect is higher following dolutegravir exposure at the conception than with the other type of ART at conception, equating to 3 per 1,000 births versus 1 per 1,000 births. The best safety data in pregnancy are for efavirenz or atazanavir, and these should be considered as first line in the pregnancy. All the women choosing to continue dolutegravir while planning to conceive will be supported in this decision and advised to commence or continue folic acid 5 milligram based on the original medical research council data on the prevention of neural tube defects in general population. For women on dolutegravir who become or is pregnant, we acknowledge that neural tube defect has closed within 6 weeks of conception, but the mechanism of some of reported abnormalities remains unclear. If dolutegravir is the best CART choice for the woman, the neural tube defect risk is of 0.30% should be discussed, and if a woman accepts this risk, then dolutegravir can be continued in the pregnancy. We do not recommend switching from dolutegravir if pregnancy is confirmed to be already past 6 weeks of gestation, unless there are some other reasons to consider switching. If the physician woman chooses to switch use regimen for, there are the most safety data in pregnancy such as efavirenz, atazanavir, or detailed anomaly scans should be performed as per national guidelines with no additional scans required. Risk of HIV transmission. Risk of transmission of HIV to the baby. Vertical transmission, untreated HIV risk is 25 to 30%. Vertical transmission, treated HIV risk is approximately 80%. And untreated HIV risk is 50 to 60% transmission to the baby. And during breastfeeding, women on CRT and low undetectable viral load, mother-to-child transmission is about 0.57%. Now, how to monitor CRT? LFTs at the start of CRT and then with every blood test. Viral load should be checked in the following way: 2 to 4 weeks after starting CRT, once in every trimester, at 36 weeks, and at the time of delivery. When to start CRT? All the women not on CRT should start CRT. Viral load of more than 100,000 HIV RNA copies per ml, CD4 count of less than 200 cells per millimeter cube at the risk or has presented with opportunistic infection in the start of second trimester, viral load of 30,000 to 100,000 copies per ml, history of the preterm delivery in the second trimester when the viral load is less than 30,000 copies per ml, and all women should be started CART of at least at 24 weeks. Now, HIV and HBV co-infection. On diagnosis of new HBV infection, the confirmation of viremia with a quantitative hepatitis B virus DNA E antigen status, as well as hepatitis A virus, CHCV, hepatitis D virus screening and test To assess the hepatic inflammation, fibrosis, and liver function tests are recommended. LFTs should be repeated at 2 to 4 weeks after commencing CRT to detect the evidence of hepatotoxicity or immune reinstitution, inflammatory syndrome, iris, and then monitor regularly throughout the pregnancy and postpartum. Tenofovir DM and amtricitabine or lamivudine forms the backbone of antiretroviral regimens in the treatment naive patients with a wild type HIV HPV infection and no contraindication to any of these drugs. If tenofovir DF is not currently part of CART, it should be added. Lamivudine, amtricitabine may be omitted from antiretroviral regimen and tenofovir DF as given as sole anti-HBV antigen if there is clinical or genotypic evidence of lamivudine or amtricitabine resistance HBV or HIV. Lamivudine or amtricitabine should not be used as the only active drug against HBV in CART because of likelihood of emergent HBV resistance to these agents. Amtricitabine has potentially increased antiviral benefits compared to lamivudine, appears to be equally safe during pregnancy, and hence it is preferred option to be given with the tenofovir. HIV and HCV co-infection. On diagnosis of the new HCV infection, confirmation of HCV viremia and quantitative RNA and genotype, assessment of hepatic inflammation, fibrosis, and liver function test, and concomitant liver disease should be performed. LFTs should be repeated at 2 to 4 weeks after commencing ART to detect the evidence of hepatotoxicity or iris and then monitor regularly throughout the pregnancy and postpartum. Pregnant women with both HCV and HIV should not be treated for HCV with ribavirin-based directly acting antiviral DAA therapies, and all women who discover they are pregnant while receiving treatment should discontinue HCV therapy immediately. Women with both HCV and HIV of the childbearing age wishing to become pregnant should be prioritized for DAA-based HCV therapy. Vaccination against HBV is recommended for all the women with both HCV and HIV after the first trimester, unless already immune. Now, hepatitis A virus co-infection with HCV and HIV. In all the hepatitis A virus non-immune women with both HCV and HIV, hepatitis A virus vaccination is recommended after the first trimester as per normal schedule 0 and 6 months. Unless the CD4 count is less than 300 cells per millimeter cube, when an additional dose of 0.16 months may be indicated. In the absence of obstetric indication, normal delivery can be recommended if the woman is receiving effective CART for HIV, irrespective of hepatitis C virus viral load. Hepatitis HIV co-infection with the herpes simplex virus. There is some evidence that HIV antibody positive women with a genital herpes simplex virus ulceration in the pregnancy are more likely to transmit HIV infection independent of other factors. Women who are HIV antibody positive and have a history of genital herpes should be offered daily suppressive acyclovir 400 mg 3 times daily from 32 weeks of gestation to reduce the risk of transmission of HIV infection, especially in the women where vaginal delivery is planned. Starting therapy at this earlier gestation than usual should be considered in a view of increased possibility of the preterm labor in HIV positive women. The mode of the delivery should be in line with the BHIVA HIV in a pregnancy guideline recommendation according to the obstetric factors and HIV parameters such as HIV viral load. There is currently no evidence to recommend daily suppressive treatment of herpes simplex virus for HIV antibody positive who are herpes simplex virus 1 or 2 seropositive but have no history of genital herpes. Now, what additional dose would you give to the preterm infant? The preterm labor. In preterm labor, if infant is unlikely to be able to absorb oral medication, consider addition of the dose of the tenofovir DF to the treatment given below. All the women should be given a start dose of nevirapine 200 mg and then commence oral zidovudine 300 mg and lamivudine 150 mg BD and reltigaravir 400 mg BD and receive intravenous zidovudine for the duration of labor. The management of the preterm serum at more than 34 weeks is the same as that for the term serum, except that the woman at 34 to 37 weeks of gestation will require group B streptococcus prophylaxis in line with the national guideline. When the preterm serum occurs at less than 34 weeks, intramuscular steroid should be administered in accordance with the national guidelines. Where HIV virus load is not controlled, this should be optimized, and there should be multidisciplinary discussion about the timing and the mode of delivery. The mode of delivery in HIV. A viral load of less than 50 copies per ml, vaginal delivery plus VBAC, which viral load of 50 to 399 copies per ml pre-labor cesarean section, virus load of more than 400 copies per ml planned cesarean section. For point 2, decide the mode of delivery taking into account the actual viral load, the trajectory of the viral load, the length of the time of the treatment, adherence issues, obstetric factors, and the woman wishes. For the vaginal delivery, follow the same guideline as HIV negative women except serum. Pre-labor cesarean section to prevent vertical transmission between 38 to 39 weeks. Pre-labor cesarean section for obstetric indication with a viral load of less than 50 after 39 weeks. Now, how to manage a case of undetectable viral load? Pregnant women with undetectable viral load at 36 weeks can be managed as per HIV. Negative women with the exception of spontaneous rupture of membrane at term when the labor should be expedited. Now, infant post-exposure prophylaxis, very low risk, 2 weeks zidovudine monotherapy is recommended if all the following criteria are met. The woman has been on CRT for longer than 10 weeks and to documented maternal HIV loads of less than 50 HIV RNA copies per ml during pregnancy at least 4 weeks apart. Maternal HIV loads of less than 50 HIV RNA copies per ml or at least after 36 weeks. Low risk expend 2 4 weeks of zidovudine monotherapy if all the criteria are not fulfilled, but maternal HIV viral load of less than 50 HIV RNA copies per ml at or after 36 weeks. If the fetus is born prematurely less than 34 weeks, but more recent maternal HIV viral load of is less than 50 HIV RNAs copies per ml. High risk, use the combination of PEP if maternal birth HIV viral load is known to be or likely to be more than 50 HIV RNA copies per ml on the day of birth. If uncertainty about the recent maternal adherence, if viral load is not known. Neonatal PEP should be commenced as soon as possible after the birth or at least within the 4 hours. In the context of a non-maternal resistance to zidovudine or very low or low risk zidovudine monotherapy is still recommended for infant PEP. If high-risk combination PEP indicated and there is a history of documented maternal zidovudine and nevirapine resistance, seek expert advice. If the advice is not immediately available, commence standard 3-drug PEP, zidovudine, lamivudine, and nevirapine until the guidance is provided. Now, algorithm for infant treatment. Maternal viral load known or suspected to be more than 50 copies per ml delivery, yes. So the baby is included in among the high risk. Okay, so maternal load from the day of the delivery found to be less than 50 copies, yes. Reduced to low risk, no, continue to high risk. Okay, so on the top, if you see that very low risk is 2 weeks zidovudine, very low risk 2 weeks zidovudine, low risk is 4 weeks zidovudine, and high risk is 4 weeks zidovudine, 3-TC and nevirapine. Okay, so here if you can also see maternal viral load known or suspected to be less than 50 copies per ml at delivery, no. So baby born after 36 weeks, 34 weeks, yes. And maternal CRT duration of more than 10 weeks, yes. And 2 documented maternal viral loads of less than 50 copies per milliliter or at least 4 weeks apart, yes. Maternal viral load of less than 50 copies per milliliter after 36 weeks, yes. So that would be included among the very low risk. If all these are no, then most recent viral load is less than 50 copies per ml, then yes, included among the low risk. Okay, but if all these are yes, from starting from here, then the baby will be included among the low risk maternal viral load from the day after delivery found to be more than 50 copies per ml, yes, intensify to low risk, and if no, continue to very low risk. Okay, so now coming to the neonatal immunization, immunoprophylaxis with hepatitis B virus vaccine with or without HB immunoglobulin given to the neonate has been shown in the separate meta-analysis of randomized control trial to significantly reduce the vertical transmission from the women with HPV alone, hepatitis B immunoglobulin should be given to the neonate if maternal HPV DNA concentrate is more than 10 raised power 6 international unit per ml, and or woman is hepatitis B E antigen positive, or anti-HBE is negative, or anti-HBE status is unknown. Now, strategies for the prevention of vertical transmission of HIV: maternal azidovirine monotherapy from 28 weeks of gestation through to delivery, and neonatal azidovirine for 6 weeks, long, maternal azidovirine from 35 weeks of gestation, and neonatal azidovirine for 3 days, short, maternal azidovirine from 28 weeks of gestation, and neonatal azidovirine for 3 days, long, short, maternal azidovirine from 35 weeks of gestation, and neonatal azidovirine for 6 weeks, short, long. Okay, so HIV-2. If woman is known to be HIV-2 infections, follow the same advice for HIV infant PEP. But if high risk combination PEP is indicated, nevirapine will not be effective. See the expert advice. If advice is not immediately available, commence zidovudine, lamivudine, and reltigaravir until the guidance is available. PEP beyond 4 weeks. Infant PEP should not be given beyond 4 weeks, even if the mother is breastfeeding. PEP should not be restarted unless significant subsequent exposure, for example, maternal viral load detectable during breastfeeding. Sees expert advice regarding the need for PEP following the breast milk exposure during the episodes of the maternal viremia. Now, pneumocystic pneumonia prophylaxis. Cotrimoxazole prophylaxis is recommended from first month of the age if HIV PCR screening is positive at any age, or if infant is confirmed to be diagnosed with HIV, and this should only be stopped if HIV infection is subsequently excluded. Infant PEP should not be given beyond 4 weeks if a mother is breastfeeding. PEP should not be restarted unless significant subsequent exposure, for example, viral load detectable during breastfeeding. See expert advice regarding the need for the PEP following the breast milk exposure during an episode of maternal viremia. Now, diagnosis of infant HIV status. A molecular diagnosis for HIV infection should be performed on the following equation: non-breastfeeding and breastfeeding infant. In the non-breastfeeding infant, during the first 48 hours and prior to the hospital discharge, if high risk at 2 weeks of the age, at 6 weeks or at least 4 weeks after cessation of the infant prophylaxis, at 12 weeks or at least 8 weeks after cessation of the infant prophylaxis. On other occasion, if additional risk, and HIV antibody testing for zero reversion should be checked at age of 18 to 24 months, and BHIVA guideline on duration of PEP have changed for very low risk infant. Okay, breast feeding infants during the first 48 hours and prior to the hospital discharge at 2 weeks of the age, monthly for the duration of breastfeeding at 4 and 8 weeks after cessation of the breastfeeding. HIV antibody testing for seroversion should be checked at the age of 18 to 24 months. Now, what are the factors which increase the HIV transmission? Factor that increases the risk of the HIV transmission via breastfeeding when the women are not on CRT include detectable viral load and advanced maternal HIV disease, longer duration of the breastfeeding, breast and nipple infection or inflammation, infant mouth or gut infection or inflammation, mixed feeding, in particular solid food given to the infant less than 2 months of the age. Now, postpartum management of the woman, antiretroviral therapy. All the women are recommended to continue ART postpartum. Postnatal follow-up of the woman. All the women be reviewed in the postnatal period by the named member of MDT within the 4 to 6 weeks time. Contraception. Contraceptive needs should be discussed with all the women, and CRT be changed to optimize a woman's contraception choice as long as ART prescribed is fully active against the virus genotype. Cervical cytology should be scheduled 3 months post-delivery as per guideline for NHS cervical screening program 2016, and testing of the partner and older children for the woman newly diagnosed with HIV in pregnancy. Testing of her partner and other children should be completed. Okay, thank you so much for your patience. That was something about HIV